welcome to the Eyecare Experts. Appreciate you tuning in and listening and viewing. Our topic for today is cataracts, and we're going to go hopefully dive into that and answer a lot of questions that you guys may have. But certainly I'm joined with Jean Terrezza, and our guest today is Andrew Sahawneh. And we certainly want you to give us a little bit of background on yourself, and don't go back too far, but just go back a little
Absolutely.
bit.
Thank you for having me. I appreciate it. It's a great honor. I'm born and raised in Mobile. Went to school at UAB, School of Optometry, and then came back down to the Gulf Coast, but I preferred the beach area, so I came down to Pensacola and joined a wonderful practice with Dr. Bell and Dr. Terrezza here at Terrezza Optical Group. I guess my main focus is more of the disease aspect of optometry. I did a residency over at the Navajo Reservation in Chinle, Arizona, which was very, very interesting, very fascinating. But again, prefer the beach side.
Yeah,
made my way back over here.
Well, we're glad you did. Glad you made this decision, and certainly glad to have you working with us.
Yeah, but I want to say that it's very competitive to get those residency positions, and he managed to do that.
He did.
And so that needs to be addressed also.
Appreciate it.
Yep. So, well, getting back to the topic at hand, we can certainly, every day we get this brought up. We either see it in a patient, or we get a question on it, or we've had a patient who's about to have surgery on it, or just had surgery on it. So, cataracts is the topic. So hopefully we can get into that a little bit. Is there anywhere you guys want to just start talking about it, or you want to kind of dive into some things that we see every day, or what do you think?
What is a cataract?
Yeah, what do you think? Is it glaucoma, cataracts? Because those two things get confused a lot.
Very often.
Yep.
I like to work on a model, which I don't have here, but there's a lens in the eye, similar to a lens in a pair of glasses, but it's made out of you. And that thing is supposed to be clear and transparent, and over time it loses that quality. Now, they argue about the biochemistry of that, and strangely enough, that hasn't been pinned down. The Japanese have come close, but no one's really gotten the final answer on that. There's one theory about sorbic acid, assuming a position, so biochemicals, hydrocarbons in particular, can assume a left-handed shape or a right-handed shape. One of the current theories is if the left-handed shape turns to a right-handed shape, it loses its ability to transmit light. And they're thinking about a drop that can reverse that process. If it does, that would disrupt the industry almost 100%, because the only method to cure it or treat it now is to take the human lens out and put a plastic one in there. The same plastic goes in your eyeglasses. And that has evolved into different prescriptions that can be put into the lens, including the prescription for your eyeglasses, the prescription for bifocals. The whole shebang can be put in there, and that's currently being developed, and I think will continue along those lines.
So cataract, you start with the lens, and there's certain areas. There's the center, there's the periphery, there's the anterior, there's the posterior. So there's different types of cataracts based on the location those cataracts are in that lens. I usually say to patients, I think we're probably all going to get some sort of cataracts if we live long enough. It doesn't mean that you're going to need surgery just because you have cataracts, but oftentimes we do. When it progresses to where you cannot see clearly enough to do your daily activities, or the glare gets bad enough. I know for my dad traveled for his job for years and years, and his vision never got so bad he couldn't see function here, but the glare was so bad he couldn't even drive at night, and that was part of his job. So he ended up having cataract surgery, removing those lenses, because you can imagine, instead of having that clear lens like you were talking about, if you shine a light into it, instead of the light going straight through, when it hits that cataract, it just kind of spreads the light. And that certainly makes the starburst, the halos, high road aberrations, things that you see at night. And I know for me personally, my nighttime driving is getting a little tougher. And that's certainly those lens changes are definitely a big part of that.
Absolutely, I agree with that. Just a little bit more, I think you were mentioning the parts of the cataract is kind of like, it's got layers, almost like an onion, where you can have an issue where it's the core of the lens, or more of the cortical, the superficial or outside area of the space of the lens. Either way, the symptoms are pretty much universal across all cataract types. Do you guys generally see them in the same patient demographics, age or race or anything like that, or does that vary across the board for you guys?
Well, I'll start with that. You can probably finish. I would say the big ones that I always ask about, as far as cataracts in general, and I get this question sometimes where they'll say, "Hey, my mom had cataracts. Am I going to get cataracts?" And to me, I mean, it's more of you and what you do environmentally in your lifetime. But there are things that contribute to that. Certainly, if you're diabetic, in general, cataracts tend to grow a little bit faster. If you're on oral prednisone or oral steroids for any length of time, sometimes that certainly can make the cataracts grow faster. If you have a job where you're outside in the UV light and that's what you do every day, all day, certainly you're going to have a greater risk of having cataracts. Certainly there's I think some family components in that, but to me it's more your underlying systemic of you and what you're doing in your lifetime that kind of determine how bad the cataracts will get. Anything you'd add to that, or is that anything you disagree with?
Smoking
that's a
and
pretty
alcohol
good one.
use can make them definitely smoking. That's a good overview for sure.
But there's different types of cataracts too. I mean, besides just, most people, we talk about age-related cataracts most often, but there are kids that we see that are born with cataracts. You can have traumatic cataracts. So there's other things there, and that's with kids especially. If they're not seeing that well, or if they're having problems, certainly bring them in. It may be a glasses issue, but it may be they were born with a cataract, especially if the pupillary reflexes, they're just not adding up, or something looks opaque or clouding or gray in that pupil. There's a lot of things that could happen.
Definitely, yeah. You mentioned the UV from the sun, the radiation, basically the energy from the sun, but the same thing, the radiation that you can get from cancer treatments can also cause those cataracts to show up unexpectedly.
Trauma can do it.
Definitely.
And even post another eye surgery. So many times retinal surgery will change the inside environment of the eye such that cataracts are a very common subsequent collateral damage, if you will, from the original procedure.
Well, I know for me, when they're getting to that point, whatever the patient is or how old they are, and let's say I can only get them to maybe 20/30, 20/40, at that point, we try to get them the best we can with glasses. Sometimes changing the prescription can help. Sometimes that can get them to see a little bit better. But of course, we can't get them 20/20 because you still have the cataract in the eye that is limiting what their best corrected acuity could be. So in those patients, what I usually do is do the best I can with glasses and tell them, we're going to see them every 6, 9, 12 months and watch the cataracts as they progress. And when it gets to a certain point where they can't see to do their daily activities, or if it bothers them and they can't do what they need to, we're going to certainly get them referred to the specialist to get those cataracts taken out.
And they all progress at different rates, too. It's amazing. Andrew had brought up, was there any difference in ethnic predisposition to doing it? And I think there is something to that. The two possible causes are genetics and environment, but they play differently in different subtypes. So you really can't, some patients stay with cataracts for 10, 15 years before they just nosedive and get worse where they can't see, and other patients progress quickly. Those are all unknown aspects of cataracts.
That's true. I sent people in their 20s, 25 I believe is my youngest, and 95 is the oldest. So pretty big range of.
And a lot of times they'll say, oh, my parents didn't get cataracts until they were 60, and I'm 40, so it's not always an age thing, right? A lot of people get caught up on that as far as, oh, I'm so too young to have cataracts, but there's so many factors that play a role in there. Age is one of those, but there's so many other things that play a role too. So, there's really no age where you could say, hey, I'm too young to have cataracts. There's things that so many things that can contribute to that. It's not anything you've done wrong. It's just the way that the eye is changing, or that lens is changing, and it's getting a little bit hard, a little bit cloudy where you can't see through it quite as well.
Yeah, nutrition is a big talk about it now, having poor nutrition and earlier cataract formation being linked.
Yep, that's a big one. What I tend, and y'all may disagree with this, but patients, it takes years usually for age-related cataracts to get to a certain level. But for me, it's like the cataracts those last 2 or 3 months when they come in and they're like, oh, I just cannot see. So it's slowly, as it's changed slowly, they really haven't noticed the decline in vision, right? But that last little bit where it gets so bad over those last 2 or 3 months, they'll come in and say, hey, doc, I can't see anymore. And that's when it just kind of gets to the point where they're really noticing it at that point.
No, I agree. That's pretty common with all my patients for sure.
And the cultural bias is I have to have it done quickly. So all this time went by, and then all of a sudden, you have to have it right now.
Right.
And that's always leads to problems because of insurance verification, time to see the specialist, time to schedule the surgery, time to do the post-operative checks, which we do in-house, and we do the pre-op also, and get that straightened out, and then prescribe glasses if necessary post all that.
Because it is an elective surgery, and a lot of insurances will try to fight to kind of limit when you can get that done. You have to be, they want you to be pretty blurry and having a lot of symptoms before they are willing to cover that surgery.
And we go through that. We'll, certainly we want, with the patient's a big part of that, hey, how much is it affecting you?
Yeah.
But also we'll look at it, evaluate the cataracts, document it in the chart and say, hey, we're this level, we're not quite bad enough where your medical insurance will pay for it, but we're going to keep watching it. When you get to that level, then we can refer you for surgery, or at least we can discuss the possibility of that at that point.
And speaking of that, we have 5 people on our insurance staff who check into the billing problems that could occur, the deductibles, what's required for that specific insurance, so we don't just turn you out the door and say, here, go to Joe Schmo's office and get the cataract surgery because he's covered by your insurance. We check all that out for you and make the best recommendation based on those characteristics.
I will say in general, I've been doing this almost 20 years. I know when I first started, it seemed like patients were very reluctant to have cataract surgery. And I think it's turned a little bit where patients know there's more options, there's more lens choices. Just because you have astigmatism, you can get a toric IOL, you can get a limbal relaxing incision. They even have a lot of multifocal options nowadays, where I think a lot of patients are, wanting to get it done a little bit probably sooner than they say, 10, 15, 20 years ago.
Yeah.
Do you
I
find
think
that?
that's true, absolutely.
So, certainly come in, let us look at it, let us evaluate it. We'll get you referred to the specialist or the right person to certainly do that surgery. Typically, most often they do one eye at a time. They usually do the worst eye first, and then 2 to 4 weeks, or depending on the other one, if the other one's bad enough. Sometimes it's just one that's bad.
And there are combination systems where you can have something with the cornea or the retina in conjunction with your cataract. And so there are specialists that do those combination type surgeries. And we're familiar with those too. And we could recommend those based on the particular case.
And one of those combination ones would be glaucoma. A lot of patients who have glaucoma and who have cataracts oftentimes get a secondary benefit of not only seeing better, primary seeing better, but the secondary is the IOP, the eye pressure being maybe a little bit lower after cataract surgery, or maybe even combining a secondary surgery with the cataract surgery to drop that IOP or that eye pressure to help those glaucoma patients out.
Sometimes to the point where you get them off the eye drops, making their, the way of life much easier, much nicer. I was going to ask you guys about non-surgical cataract treatments. So they come in, they're not ready for surgery. What do we do? We're prescribing glasses. A lot of times I'll add the anti-glare coatings, UV coatings to limit it from progressing, getting worse. Are you guys doing anything else on top of that?
I recommend a Polaroid lens to cut out glare.
Gotcha.
And you can do it either in a clip-on or in the lens itself, depending on the prescription.
Polarized.
Yeah.
You said polarized.
Yeah. So we do that, and we do that in-house too, so we have very good control of how those lenses are made, and if adjustments need to be made, we take that into consideration.
It's UV protection, getting it corrected the best we can with glasses, getting, cutting down the glare the best we can, anti-reflective, anti-glare, doing what we can to get these patients seeing the best we can. But oftentimes when we check the prescription itself, let's say the patient we've seen the last couple of years and they come in and their prescription is different, or there's been a shift in the prescription. Sometimes we think blood sugar, sometimes we think diabetic, but also cataracts. Cataracts, as it gets worse, can also change the prescription, and sometimes that helps us indicate what cataract it is based on the prescription and the shift and the change.
Definitely.
So, if you're not seeing well, and I have some patients that are that level where I have to see them certainly not once a year, but, maybe every 4 or 6 months, because we're watching it. And if there's a change in that prescription, we want to do the best we can, or get them seeing the best they can up until the point where we can do surgery on those patients.
Many times a patient will come in who is unhappy with their other practitioner, and they said, well, I still can't see well, but they didn't understand the type of cataract they had, and that correction to what they used to see in their 20s is not possible. So that's very important to explain that to them, and they're satisfied once they get an explanation.
Then we want to talk a little bit about post-op, maybe, as far as what to expect after the surgery, drops, coming back and all that stuff.
I think the vast majority of people, I believe the statistics, over 90%, have better vision day one after the surgery, or 1 day after the surgery. Usually have some swelling going on, and you're on eye drops for, well, most of the time you're on eye drops. There are a lot of newer surgeons that are doing the intravitreous, or putting an injection in the eye during the surgery, the time of surgery, so that you're not using anti-infectives or anti-inflammatories after the surgery for a month straight. But the vast majority of our patients, I believe, in this area, and our surgeons do follow the dropped formula, the protocol.
But there is some risk associated with that convenience. So the fact that you get that, if you have complications from that, they were all because the only thing on the plus side was convenience of not putting the drop in. So we have to be somewhat practical and use our common sense as to gain versus risk.
So important. I mean, to that point, very important to, talk to the surgeon. You can ask us, but certainly, what's the protocol after the surgery? What drops do I need to be on? How often do I need to use them to make sure I'm healing properly? But again, to make sure I don't get any secondary infections, because to get to the cataract, they have to make a small incision in the cornea to go in the eye to be able to phaco or take out the cataract that's there. And luckily nowadays, the lenses are so tiny, they're folded up where the incision is much smaller nowadays than it was, 20 or 30 years ago. So that's definitely improved, but you still have to make an incision in the cornea to get inside of it. And oftentimes we want to make sure that heals right, to make sure there's nothing that invades the cornea, and to make sure, the patient's okay. Because a lot of times I see patients with complications. And some of those times it's because patients are not using the drops that they should. They didn't start on the drops prior to the surgery. They're not doing some of the things that they should be doing. Not always, but that's certainly some of the times. But as far as healing post-op, certainly you mentioned day after you can see well, but I also will say there are, as the eye heals, there may be some days where you see better than others, as far as going back and forth. You may have a little bit of corneal edema, things like that. So to me, what's important is when the eye is, let's say 4 to 6 weeks out after surgery, what are you seeing at that point? What does the cornea look like at that point? But make sure, we do post-op care. We certainly co-manage with pretty much every surgeon in the area. There's some insurances that don't allow us to co-manage, but we certainly co-manage the ones that we can. Before we get any questions, anything else we want to talk, anything we didn't cover on cataract surgery or the follow-up care or anything that you've seen? Or
one thing I would probably want to add is just the implants. That most insurances cover the basic implant that allow you to see either distance or up close, one or the other, and you would need corrective lenses for the other portion there. Or you can opt in and pay a little bit extra for a lens that fixes astigmatism or allows you to see far away and up close at the same time.
Yep. Well, I'm gonna go through, we've got a couple questions here as well, so let's dive into a couple of these. Where is that first question? I thought I had it here. Here we go, question 1. And this is actually, if I need surgery for my cataracts, do you do that in your office or do you refer me out? We talked about that a little bit, but kind of go through that.
We do refer out because we do what we do. I think people should stick to what they do best. So people that do cataract surgery only occasionally will not do it as well as people that do it all the time. Just like with primary care that we do, if you do it all the time, you tend to be better at it. I think that goes for any occupation, any skill done by human beings. So that's what I'll say about that.
And we have several fantastic surgeons around the area, so why would we do it ourselves when we have others to refer to?
Second question, we currently do not have vision insurance. What is the average cost for a comprehensive eye exam and a pair of glasses if I need them? Well, you know,
Variety.
I guess what I would say on that before, and y'all can jump on that, is even though you may not have vision insurance, we take most every medical insurance that's out there. So if you have medical insurance for your body, you know, we find a medical diagnosis, we can certainly bill that. So I would say, you know, certainly call us, and if you have any vision medical insurance, you know, let us know. We'll look it up and let you know. But our basic comprehensive exam is $99. As pair of glasses, we have them priced. I think we have package deals, and so part of that will be on the patient. You know, what frame you're looking for, what lenses. But I think if you come in and see us, I think compared to everyone else, our prices are pretty comparable. That's the one thing that you've kept down, and we've tried to do our best to make that economical and make it affordable for pretty much any patient that we see.
Well, the fact is that many of the insurances, we're the only providers in the area stretching from Fort Walton to Baldwin County, Alabama. And I'm very proud of that. So if you have any kind of insurance at all, the odds are 95% that we'll take it, we'll bill it for you, and that will cover your bill. So the answer to that would be zero out of pocket.
Right.
Some of them do have $2 deductibles.
Well, we want to thank Andrew for joining us for this topic on cataracts. Appreciate you guys listening, and like us, comments, keep the questions coming. Until next time, thank everyone. Thank you.
Thank you.
Thank you.